Good afternoon, everyone. It's a pleasure to be here and an honor to be speaking before all of you. And I'm sure after an afternoon siesta, you would all be fresh. We went out for a walk and completely refreshed from the walk. Injury is a disease. And I emphasize that because a lot of health professionals do not recognize it that way. The only difference between the disease process and the disease is a disease is caused by a bacteria or a virus, and injury is caused by energy. And exactly as the bacteria or the virus takes a little while for the disease process to be apparent visibly, injury also takes time to manifest the full consequences of transfer of energy. And that is important, and that is why the time sequence after an event of injury becomes important. A rupture of the intestine may take 48 hours to manifest as a serious injury, whereas a rupture of a vessel, the patient may die within hours. The person, therefore, after the injury is evolving physiologically. There are changes happening as a result of the injury and is constantly evolving physiologically. And that's important. The outcome of injury is not always very good, but different age groups, different conditions will modify it. And the most important is the severity of trauma, which is determined by the extent of energy transfer to the patient. More the energy, greater the severity, and greater is the vulnerability for the person to succumb to the consequence of that injury. Other factors are also contributing, including comorbidities, age of the patient, younger, older, vulnerable. So many factors are there. But important thing again, because time is critical in evaluating the consequence, you must understand the person goes through the injury and the healing phase. It takes time. So you need to follow the patient from the time of recognition to the emergency room, to the ICU, to the operating room, to the ward, to the rehab center, and then back home in the community. It's a whole continuum that is important. However, medical science has evolved a little differently. Depending on needs and the burden that has been there, they have been evolving in compartments. So you have little boxes of different compartments of the bystander care people, the first aid people, the ambulance people, the EMS people, the emergency room people, the ICU people, the intensivists, the OR staff, the trauma subspecialties, rehab services, and the psychologists that come in post-traumatic stress disorders, and the vocational and the social rehabilitation. Each one works in his own silo, and they do not communicate with each other, could lead to a problem for the patient. So it's important that the linkage is seamless and they are able to communicate the transfer from one to the other seamlessly. That's important. A team approach is therefore important for trauma care to be good and efficient. There are enough literature on this, how lack of team approach leads to problems. For example, the emergency medical service, the paramedics, that is a recent introduction into medical curriculum. And they work differently. They don't gel well with the hospital people. So in institutions where there is no linkage between the two, which are effective, they have problems in transferring patients and they have problems in survival. The literature on that. Pre-hospital is all that you do before the patient reaches a hospital to get definitive care. And historically, it evolved in the battlefield. The Napoleon's war, doctor. Even today it's evolving. If you look up the literature, the tactical combat casualty, which has come from all the casualties in the Middle East, have led to a lot of understanding and a lot of new papers, research papers on the outcomes of interventions in trauma, and new guidelines are being set based on that. We have the battlefield in the cities, that is the roads, and we do have the outcome of problems happening in these being evaluated in different sessions. But what we do in these settings, what is the evidence? That is the question. We do not have sufficient evidence for many of these things. And there's reason for that again. Over the years, protocols have evolved, and many have been evolving over time, 60, 70 years. Modern medicine is only 60 to 70 years old, not older. Your 1950s understanding of head injury, 1953, the whole understanding on cardiac arrest, 60s, the resuscitation technique that we have, the cardiopulmonary resuscitation technique that we have, and the use of saline as a substitute for blood loss was 60s, and 70s saw the invention of your ultrasonography, 80s saw the invention of CT scan. So we have only very recent, and antibiotics came up only in the early 40s. So the protocols that we have are all recent, and they have been added on one by one to the medical curriculum. We have different protocols for pre-hospital care, the basic life support, the advanced life support, advanced trauma life support, pre-hospital trauma life support. Different technologies are there, each one with a different skill set that is expected from the person. The German group, anesthesiologists, trauma surgeons, radiologists have got together, have an S3 guideline protocol, which tells you what to do, and most of it is consensus based. Consensus based protocols, a group of experts get together like this and come together, okay, this is what we must do, rather than studying the data, studying the outcome, studying the intervention, and then finding out what works and what doesn't work. That's evidence based. So what has evolved in pre-hospital care has until recently been only consensus based. The sequential response, compartmentalized, is not an efficient method in trauma care. It has to be a seamless care. A sequential response leads to delays. Starting from the response time, we do not have universal response numbers for trauma across the globe. We have different countries, different continents having different numbers. You may get 911 as most popular because you see it in movies. But beyond that, there is no consensus on a uniform number. Triage is sorting the patient to match the demands the patient has from injury to the facilities that is there. So there's no point in taking a head injury patient to a person who has a hospital which does not have facilities for CT scan, who does not have a neurosurgery team. So it's important to match the two, and that triaging happens right from the site of injury. The sorting is important, and it can be challenging. It can happen at different levels, from the time of injury. At the time of injury, when you're making a call, there's a critically injured patient in the site in this crash area. Inform the on phone, whatever is the emergency number, inform them so they are already prepared. There's a triaging which happens at the scene by the paramedic that reaches there, and on the emergency room there is another triaging that happens. He goes to neurosurgery, he goes to surgery, he goes to orthopedics. That's the triaging that is happening, sorting out. There are triaging criteria that have evolved over time. CDC has its own criteria based on the consciousness level, the Glasgow Coma Scale, based on the blood pressure and the respiratory rate. That's one set of criteria. But there's another step criteria that is based on the type of crash that the person was involved. So you saw those video clippings. So if you had an advanced information, you can anticipate this person is expected to be having such a severe injury that he needs straight away go to a very high-tech, well-equipped center with competent specialists. And that's important. This patient was taken to a secondary hospital, and she had been hit by a motorcycle and had a fracture of the forearm. The doctor there saw, got the x-ray done. She had some pain in the back, got an x-ray chest done, and I got a call from the secondary hospital the patient's relative found out my number and called me up, and this patient has this problem, has a fracture in the forearm and has something in the back. We are shifting her. Okay, she comes over, I get her x-rays done, I examine her clinically. She has a bad fracture of the pelvis. All the arrows are marked there, including a doubtful fracture in the hip. I look at the spine x-ray, I don't find much, but the x-ray of the rib is there, which I could see on the computer. There are some fractures of the rib. X-ray chest was normal. Meanwhile, the relative got this clipping over to me. The person who fell away, that's the one who was the victim. And I looked at that and I knew this couldn't be just a forearm fracture. It had to be something more serious. So, when she came to me, I evaluated her, immediately asked, checked her abdomen, checked her, she has pain in the ribs, pain in the chest, there was something in the abdomen, so I got an immediate ultrasonography done, got immediate CT scan to be ordered for. The CT scan showed she had a head injury, contusion, subarachnoid hemorrhage, fracture in the skull, with rib fractures, with the CT of the lung showing hemothorax, and there was a fake fracture in the sacrum too. So there is multiple injuries which could be predicted if you know from the site of the crash how the patient has fallen. So that's a way of triaging to a level different from what you anticipate. So that's the importance of having a seamless, continuous evaluation and continuous understanding. So this patient was treated. Just before I came here, we did the surgery and got a forearm fixed, but the others needed conservative treatment. But important to understand the key components of managing these cases right from the beginning. Take care and follow up. Her rehabilitation will take a long time. It must begin even as she is in the hospital. The key components again include the ABC of life support. And this has also been changing from the 60s when we started. So until 2010, almost 50 years, we have been taught a particular method of doing a cardiac massage. It has now undergone change. They found that bystanders can do just the chest compression, and that is still good enough for survival of the patient. So this is an important part of evolution which has come after evaluating the outcomes and evaluating the methods that we use in trauma. So merely not going on consensus but on the actual functioning. However, in trauma, if there is a cardiac arrest happening, that's usually a person who is bled, and it's the bleeding and hypoxia that contributes to it. Quite unlike an MI patient, the outcome is usually very poor in these cases. There's technology now evolving in everything. So this is also a technology. You can do a massage, cardiac massage, using a special technology that is there. I don't know how common it is here, but it is coming up in many countries, being pushed as better than the manual one. However, there is no evidence that mechanical CPR is better than the manual CPR. Again, if you need to have ventilatory support for a seriously injured patient, you have to plan for the person to be taken to the operating room, then to the ICU, and then how you wean off the person from the ventilator. So it's a process which is required. Uncontrolled hemorrhage continues to be the major cause for death, and one of the substitutes for bleeding is intravenous fluid, and which again till the 2010 decade we have clear understanding that you have to have an IV line started on the patient from the time of injury. So in the ambulances, they are the ambulance paramedics will be putting in intravenous lines. However, if you look at the physiology of bleeding, unless you control the bleeding point, giving intravenous fluids actually encourages the bleeding to continue. And the normal compensatory mechanisms that happen in physiological methods in the patient are prevented from happening. Because the blood pressure is artificially maintained, the leaking continues. And if you were to look at the analogy, If you put in an open loop and put in fluids, with time the blood will be drained out of that open area. Eventually there's no blood for circulation and no oxygenation, and the patient is going to be dead because of hypoxia. Why don't we see this very often in city lives? That's because the transportation time in urban setting has been low, and the actual volume of fluid that goes into these patients is also low. Therefore, we don't see the consequences. But if we actually are able to put in more fluids, we will have problems, and they have enough studies on this. We go on the literature, you'll find several reports that show the lack of benefit of intravenous fluids. So if you're pushing your ambulance people to get the patient, don't push for intravenous fluids, push for early transfer. Volume replacement, now they talk about balanced resuscitation. Don't push for too much of fluid resuscitation. You can restrict it, but how long can we restrict it? How safe is it to be? We still don't know the science. It's still being evaluated. What about drugs? I'm sure there are some drugs which we can use, but this is a picture from a country where the paramedics told us very clearly, please don't talk about this from the country that we are giving it in. Our biggest problem, they said, was these are drugs which are mostly narcotics, painkillers, and the junkies want to steal this when we are rushing up to pick up patients from the injury or homes. So narcotics are a problem. It's a huge problem in the US now, with a large number of deaths and overdoses happening from narcotics. The only drug which is shown to be beneficial, I don't know, is it being used here, tranexamic acid? It came up from a research. It's an old drug, it's not a new drug. In the 60s it was used for women to control bleeding. So this is a technique which has been evolved after a crash through trial, and there they found that it is very useful. Within 3 hours of an injury, if you give, it reduces the mortality, it reduces the bleeding in these patients. So there is high level of evidence that tranexamic acid is useful in the pre-hospital care. In the UK, for example, they have introduced it in all emergency ambulances across UK, that they have to have tranexamic acid available in the ambulance, and they give this to a patient immediately after injury, and within 3 hours it is most effective to be given for patients to improve their survival after an injury situation. First aid, yes, the person with cell phones all over, you can always call for help and get the person to have access to a healthcare facility. They can also provide basic helps. However, the advanced life support looks at several interventions and several technologies. And basic life support looks at just keeping the airway clear for breathing and making sure that patient's bleeding is less by elevation or by pressure. Those are simple techniques that we do. In a recent study, they found that interventions that you do in the pre-hospital, like the advanced life support, will not contribute to a better survival. Very clearly, compared to those that received basic life support, ALS patients had poorer outcome and longer duration of stay. Again, the spine boards that are recommended, they found complications with those boards, and including the cervical collars that are being used, they found problems with the use of collars and complications associated with this, including more patients choking on this. So there are several reports on this, on the use of this. So the important thing that I am emphasizing is all that is done in the pre-hospital ambulance is being challenged now because of lack of evidence. However, early intervention to a definitive care facility is what makes a difference. For example, they found that those spinal cord injured patients that take more than 24 hours invariably have problems, and long-term rehabilitation in these patients are very, very challenging. You would imagine the ambulances would be the vehicle which you expect to be transported to a hospital when you are injured. 90% of patients in high income countries are transported by ambulances, whereas 90% in low income countries are transported by the non-ambulance. So this is India. We have 4% being transported by ambulances in one study, 3% in another study. Rest all went by other vehicles. Speed is considered critical. That's why the concept of golden hour. The golden hour is more of a verbal rhetoric by the American College of Surgeons describing it in one meeting, not based on evidence. How much is the golden hour to keep the patient safe? We still are struggling to understand. But it's important to have a good response time to get the patient to the definitive care facilities. Sirens and flashing lights, they don't really change much. Mean time in 50 trips saved was just 45 seconds. In another study, 2.9 minutes was the saving after use of flashing lights and sirens. Crashes are increasing with high speeding with ambulances. Therefore, these studies have been coming up, including helicopters. Helicopter ambulances, higher number of crashes, and 120 killed from 1998 to 2012 in the US alone. So there is a large number. But improving pre-hospital care without improving hospital care is useless. The whole trauma team concept evolved in the UK, and we have a team of orthopedic, anesthetic, surgical, nurses, radiologists, all working together as a team, and this is something which should be pushed up in hospitals in our region so that the patient gets the best once the patient gets to the hospital. Multiply injured patient needs to get to a tertiary care where all facilities are available for trauma care and all the specialties are taken care of. Missed injuries are a problem, and this is usually because the doctors tend to work in a different manner when they're evaluating patients. That's why primary, secondary, tertiary evaluations, repeated evaluations of our trauma patients, because the consequences take time, maybe hours to develop. You've seen the patient 1 hour back, go back and see again because they may have found some other finding in him. So that's what it is important. So the tertiary surveys have been found to reduce the missed injuries in these patients. Please remember, physicians have cognitive problems by looking at the patient at a given time. They jump to conclusions and they may leave the patient there thinking this is the only injury that is there. So to avoid missing injuries, you have to understand how doctors' minds work. And the way they work is on heuristics. They see a fracture, oh, this is what it is, start treating that without looking for the other things. So there is a trauma care checklist protocol that has been evolved, which looks at the patient at arrival, after an hour, and subsequently also evaluating constantly to look at that you have not missed any injury in this patient, because trauma is evolving. So in different phases of injury care, we need to make sure that we don't miss out anything. So recovery from trauma needs long-term rehabilitation also. And that also has to be built up in our centers. That is a neglected area. All districts do not have, at least in India, all districts do not have rehab centers. I was reading about this, that you do have a linkage between different levels in different counties in China, but I would be happy to see what's happening here. WHO recognizes there is a lack of research in this, and long-term studies are not there because long-term studies are very expensive. There's a large gap in the research availability here, and research is difficult. That is why so few evidence-based interventions. Research is really difficult, and what we do is being evaluated constantly. Newer techniques are coming up. For example, the whole concept of early hypovolemic recognition before the physiological parameters change is a serious research that is coming up called compensatory reserve techniques. These are issues which are under investigation, and we need to have constant research to have good outcome. So until we have the evidence, we need to scoop and run with the patient, with the injured, to the nearest hospital with a trauma team, and on the way, perhaps the only evidence which shows is give basic life support and give tranexamic acid to control bleeding. So we need to focus on the hospital care improvement as far as possible. Preferably multi-specialty care, not just simple trauma care. It's a continuum. We work towards from injury to back home and back in the community. It's a seamless integration that is required. Thank you very much.